Thank you for the privilege of the podium. It's my pleasure to present transanal total mesorectal excision for rectal cancer beyond the learning curve. We have the following disclosures. So transanal total mesorectal excision for the curative resection of low and mid-rectal tumors has increased rapidly worldwide since its adoption in 2009, and it's demonstrated good short-term oncologic outcomes in large case series in an international taTME registry. However, because we are still in the early phase of its implementation among the grand surgical community, the expert consensus is that the exclusion criteria should include T4 tumors requiring exenteration, prostatectomy, extensive pelvic adhesions, unresectable disease, and tumors with potentially positive margins. taTME requires a structured training and high volume for us to be successful. In recent studies in 2018, the taTME learning curve was studied, and institutional proficiency was shown to be achieved at 40 or 50 cases based on TME quality and postoperative morbidity. Also of note, with the largest series of taTME to date, the international registry was actually from data where 20% of the surgeons had performed more than 20 taTME cases. So the purpose of our study was to analyze the outcomes of taTME performed by 2 surgeons beyond the learning curve, and to evaluate the expanding indications and the evolving role of taTME at centers of expertise. Our methods: we had an IRB-approved retrospective analysis of patients undergoing taTME for rectal cancer at 2 tertiary care hospitals from 2014 to 2019. All transanal procedures were carried out by 1 surgeon at each institution who performed more than 50 taTME before the study period. Tumors were staged with pelvic MRI or endorectal ultrasound if that wasn't possible. They were all evaluated by MDT discussion, and they underwent neoadjuvant treatment followed by restaging MRI according to their recommendations. Our exclusion criteria included tumors located greater than 10 centimeters from the anal verge, invasion into the puborectalis and external anal sphincters, T4M1 disease that did not show good response with neoadjuvant therapy, and the patients that were enrolled in the phase 2 taTME clinical trial. Our results show that 74% of our patients were male, 28% were obese, 3 patients presented with recurrent rectal cancer, and 1 patient failed after a watchful waiting protocol after chemoradiation. Out of the patients that had prior abdominal or pelvic surgery, there were 4 who had liver resection, 2 of which were for hepatic metastases, 2 for cholangiocarcinoma. 2 patients had a low anterior resection for rectal cancer previously, 1 prostatectomy, and 1 brachytherapy. 55% of patients had tumor height 6 centimeters or less from the anal verge. 75% of our tumors were T3. There were 4 patients who presented with T4 disease and 4 patients that presented with distant metastases. 47 patients underwent staging MRI, and 7 patients underwent endorectal ultrasound. There were 12 patients with a predicted positive margin. There were 4 patients with involved internal anal sphincter muscles, and there were 31 patients that went on to get a restaging MRI. 47 patients in all received neoadjuvant chemoradiation. Overall, taTME was performed with low anterior resection, APR, total proctocolectomy as shown. The operative approach was primarily with laparoscopic assistance with either TAMIS or TEO platforms. There were 11 intersphincteric resections that were performed, 9 of which were partial. All patients got a stoma. There were 5 permanent colostomies and 2 permanent ileostomies. Anastomoses were hand-sewn or stapled, and specimens were primarily extracted transanally. Intraoperative complications were 14.8%. That included anastomotic defects, a number of 3 enterotomies, 1 vaginal tear, and 1 ischemic conduit. There were 5 abdominal conversions, 1 for a BMI of 47, 2 for redo LARs after recurrence, and 2 with difficult anatomy from adhesions. The postoperative 30-day morbidity was 42.6%, 3 of which were pelvic abscesses, 1 aspiration pneumonia, 1 mortality due to C. diff, and 1 mortality due to PE. Postoperative complications beyond 30 days was 24.1%. Of interest was the anastomotic leak. There were 5 that manifested as 2 anastomotic strictures that were managed with dilation, 3 asymptomatic sinuses that were managed conservatively. There was also 1 mortality due to ARDS. Final pathologic staging showed that none of the tumors were T4. A majority were T3. There were 5 patients that had complete response after their chemoradiation. There was a 94.4% rate of complete or near complete TME specimen quality. There was a 3.7% rate of positive circumferential resection margins, and there were no distal margins that were positive. With a 28-month follow-up, a median 28-month, overall survival was 94.4%. Disease-specific survival was 100%. There were 42 patients that showed no evidence of disease and 9 who are alive with disease, with a disease-free survival median of 19 months, ranging 0 to 50. Local recurrence rate overall was 3.9%, distal recurrence rate 17.6%. When looking at just the stage 1 through 3 cancers, none of those patients developed a local recurrence, and 6 of those patients developed distal recurrences. When looking just at the stage 4 cancers, or the patients that presented with a local recurrence of rectal cancer, 2 had a local recurrence and 3 had a distal recurrence. Our study is limited by the sample size and the follow-up period, the retrospective design, and we were not able to get functional data. However, we do show that taTME by surgeons beyond the learning curve does demonstrate acceptable perioperative morbidity with adequate short-term oncologic outcomes and a disease-specific survival of 100% at 28 months. So what is the role of taTME at centers of expertise? Perhaps it's expanded indications for patients with a hostile pelvis, patients with selected T4M1 cancers that show good response after neoadjuvant chemoradiation therapy, patients with potentially positive circumferential resection margins. These patients would be best served with taTME to have the greatest chance of an R0 resection. Patients with a positive or involved internal anal sphincter muscle, a taTME can be performed with intersphincteric resection with good results, as we've shown. And patients who present with local recurrence of their rectal cancer. Thank you.